My name's Laurie Brinklow. I am the interim coordinator of the Master of Arts in Island Studies program at the University of Prince Edward Island, and also the interim chair of the Institute of Island Studies Executive Committee. I am also the treasurer for Canadian Rural Revitalization Foundation. So when we're very much an active and working board, and so when we're asked to do stuff, we say yes. And I'm very pleased to be asked, to have been asked to be the moderator for this panel on care and community, where we'll get to hear from Dr. Lauzon, Dr. Kathleen Kevaney, and PhD student Katie Allen. So we'll go in that order. And Lauzon is a professor in the School of Environmental Design and Rural Development at the Ontario Agricultural College at the University of Guelph. He's going to be talking to us about long-term residential care, COVID-19, and a political culture of neglect and the implications for rural. And that Rural Insights paper is on surf.ca, where you can also catch it there. So Al, I invite you to take over the screen.
Okay, thank you very much, Laurie. Okay, so I'm going to talk a bit about long-term care, and I'm sure that anything I say today, people are probably aware because long-term care has been in the news so much. But I was really looking, and I like this word cloud to start, and I like the word cloud because it's disturbing to me. And it looks chaotic, and it in some ways embodies the times that we're living through. And certainly we're living through some interesting times. I'm going to talk today about some systemic issues that are common to urban and rural long-term care, and then I'm going to look at rural implications. But one of the things I wanted to do is I want to start with a story. And I want to start with the story because we see lots of statistics. But we need to remember that behind every statistic, there's a human life. There's a story there. There's people who love them. There's people that they love. So I'm going to tell you about Betty. This is a true story, but Betty's not a true name. And the image is not the person. I stole it off the internet. And that to protect some anonymity. So Betty is an 80-year-old widow. She's a retired nurse who's been living with her daughter for the last 4 years. She was starting to suffer from falling a lot, and she ended up in the hospital on 2 or 3 occasions, never broke a hip or anything. She suffers from numerous chronic conditions. She suffers from macular degeneration. Her sight is not very good, and as a lifelong reader, that is very distressing to her. She has congenital heart disease. She has arthritis. She has a opening in her abdomen that I don't know what you call. It's not an ileostomy or anything, but she has an appliance there that has to be cleaned every 2 days because she had part of her bowel taken out and has had bowel problems. She also has her knees are shot, and she was in need of knee surgery, knee replacements, but she is not a candidate for surgery, so she has to live with this. That really limits her mobility. She went into the hospital and it became apparent that she wouldn't be able to go back to live with her daughter. And while she was in the hospital waiting placement in a transition bed, she contracted MERS, which put her in isolation. So this started in September. And so she lived in isolation for a while, and then she got over MERS, and she thought she'd have to be placed in a transition bed, and she was placed in a transition bed. And the transition bed in a retirement home, she contracted COVID-19. And her roommate, she suspected being a nurse, had COVID-19, and Betty kept asking the staff about it, and they kept lying to her, saying, no, she doesn't have COVID and we're not testing her for COVID. Then they came to Betty and asked Betty, said they had to be tested. She tested positive. She was moved out of the hospital one night along with a number of other patients. Her roommate did die, and she ended up in the hospital in isolation again. She's one of the lucky ones. She survived COVID-19 and she was discharged to a nursing home. So we need to remember that behind the numbers, there's always a story. There's always a life, and that's really significant. As of May 25th, there'd been 5,324 deaths in long-term care in Canada. That number would be higher now. That comes from a CIHI report. Long-term care residents accounted for 81% of COVID-19 deaths in Canada. We, I think, have one of the worst records in the world for our seniors. Mortality rate for those infected with COVID in long-term care was 35%. So 1 in 3 died. And COVID workers, almost 10,000 have been infected, representing almost a little more than 10% of the cases. So what is it with long-term care? Really, it's the case that there are a variety of systemic issues. First of all, there's a changing nature of long-term residents, and residents are actually much older, much frailer, and have much more complex care needs. So roughly 82% of long-term care people are over the age of 75, and probably 54% are over the age of 85, and 10% over the age of 95. So the demands of care are really quite astounding. There's inadequate staffing and an aging workforce in long-term care. As care becomes more complex, the residents become more needy, requiring more assistance in a variety of things. We've actually seen some problems with staffing, not enough staff. And the workforce who works in long-term care, over 60% of the workforce is over the age of 40. The work becomes more physical, more demanding, and more complex. 51% or a little over 51% of care in long-term care is delivered by people who are employed precariously. What does that mean? That means that they're part-time or they're casual. They don't usually have benefits, and they're not necessarily guaranteed hours. They often work in numerous nursing homes in order to cobble together a living. And as we saw in Ontario anyways, the government curtailed that. And why that was a good public health move and good for the long-term care residents, it didn't take into consideration that it eliminated somebody's income and livelihood. And that long-term care ownership is a major issue. And so increasingly we're seeing the privatization or for-profit ownership in long-term care. We know a few things through various studies that they have lower staff levels than nonprofits or municipally owned care or long-term care. They deliver less hours of care, direct care to individual residents. And over the course of the pandemic, they've had much higher mortality rates in those homes. And we've seen a lot in the news about it. Physical structures, a lot of the long-term care facilities are old, and they create problems. One of the problems that they created, and it's interesting, in Ontario in 1998, there was regulations passed that said they had long-term care homes had to get rid of wards, and that only 2 people should be allowed into a room. 22 years later, it hadn't been enforced, and that was a major problem that we have. Now long-term care homes are saying we need more money to sort of adjust and to really look after the necessity of infection control and within the context of the physical structure and how those people are housed. And a lot of the problem actually was in the for-profit nursing homes in terms of having these wards, and they're now making the argument, well, government needs to help us out. Well, they've been making profits for the last 22 years because they failed to live up to it. And the government has failed to live up to implementing the regulations that they actually provided. And also a failure of government. So in Ontario, every long-term care home is to have an annual inspection. In 2018 or 2019, there were 9. So they're failing to inspect it. When we look at rural populations are older and more likely to suffer ill health, chronic disease, including the workforce. That has implications for long-term care, but it has real implications for the rural workforce too. We have an older workforce in rural areas. There are fewer healthcare resources available in rural communities, so there's a shortage of psychiatrists, and there's definitely a shortage of geriatricians. Very few geriatricians. I only know of one in Ontario that works rurally. Training, attracting, and retaining long-term care staff is problematic because the educational facilities aren't necessarily there, or the broadband's not there to do training online. So sort of that classic story of not being able to have access to the resources. One study that I looked at found that homes with the highest rates of abuse in Ontario were in Eastern Ontario, and over 50% were in small towns. That's an interesting, and we can hypothesize why that might be the case, but I'll leave that for another day. And less opportunities for ongoing continuing education within facilities and having limited access to other educational programs. As care becomes much more complex, there's a need for continuing education. We're going to be facing an onslaught with dementia and Alzheimer's, and that's going to be a problem. Transportation in rural areas, as we know, is always an issue, and that will, as we look at wave 2 coming down the road, along with flu season and snow, at least in some parts of rural Ontario, it can create a staffing problem and a staffing shortage. We're now gearing up for wave 2. I sit as chair of a small hospital board, rural hospital, and I sat in a meeting last night, and we were asking leadership about wave 2. They're scared. It's going to be much worse, they think, than wave 1 in terms of adapting. And the biggest risk is human health care resources, so the people who actually bring it. I asked what our long-term care partners were like in terms of staff, and we're not prepared. And I think that will be common. So long-term care in Canada represents an ongoing healthcare crisis in Canada, but perhaps more important, it represents a moral crisis. Our seniors deserve better, much better. Governments have failed our seniors, and it's a case of culture of political neglect, and I would also suggest ageism. I just want to return to Betty for a minute. How's she doing now? Well, she's adjusting to life in a nursing home, but is struggling. One of the things, and I know this individual personally, one of the things she's struggling with is an acknowledgement that this is her last home, that this is where she will finish out her days. Surrendering her autonomy, not being able to eat when she wants, not being able to have a bath when she wants. She's had some visitors, and the visitors are outside, and you still have to respect social distancing. So she's seen her daughter, she's seen her adult grandsons, and that. When I talk to her now, there's some confusion there that wasn't there before. I don't know whether it's hospital delirium or perhaps early onset of dementia, and she's afraid. She's not afraid so much of COVID-19 as she is about, and there's lots of spelling mistakes on that, I apologize, about the isolation from the people she loves. So I just want you to close with the thought that there are people out there, elderly people, who haven't been able to hug, who haven't been able to kiss their loved ones, and in a lot of cases, we're not able to say goodbye personally to that. So I'm going to end there and say thank you.
Thank you, Al, for putting a face on so much of what we heard in the media about the issues in long-term care facilities across this country. And it really is a sobering wake-up call. And I'm looking forward to hearing some discussion after we finish the other presentations and seeing if people have some ideas out there how we might address this. Thank you again. Next up, we have Dr. Kathleen Kevaney. She's an associate professor, Department of Business and Social Science at the Faculty of Agriculture at Dalhousie University, just across the water from me here in Prince Edward Island. She's prepared a Rural Insights paper on rural mental health during COVID-19, and I invite Kathleen to take the screen.
Thank you so much, Laurie, and what a privilege this is to be on this esteemed panel with Katie and Al. So I am going to share my screen as well. I am going to talk about the work that Ashley inspired with the Insight Papers on mental health, rural well-being, and COVID-19. And this was done in collaboration with Dr. Andrea Jones-Bitten from the Ontario Veterinary College, Director of Wellbeing Programming. What a cool title. And myself with the Director of the Rural Research Collaborative. So what is it people want from their lives? You know, all of us were seeking serenity and peace, freedom and liberty, health and well-being, of course. And of course, we want happiness based on our loved connections, meaningful and frequent attachment to people that we care about. And of course, we all need sufficient access to resources, financial, natural, and social capital. And during COVID, what we knew in our lives was taken away from us abruptly and in many cases violently. You'll remember in Nova Scotia, there was a massive killing just at the beginning of the outbreak as well. There was tremendous distress people were facing. And from a psychological perspective, distress arises from our perceived gaps between what we need and want and what we get, and between what we perceive others need and want and what they get. And the Buddhists could give us some insight about some of this, but for purposes of our looking at it, we're going to examine what the literature is telling us about how this is manifesting. So for our design, we had a quick turnaround time. So we built upon recent research that both Andrea and I had done separately. And we undertook a bit of a review of the literature on rural and mental health and impacts from COVID. So what do we find? Some of the risk factors of mental health. People in rural and remote areas experience more directly and immediately than those insulated urban residents the impacts of healthcare crises, climate change, and unsustainable development. And they then are more at risk as they face amplified adversities. Rural residents may face compounding challenges through the disruption, the social isolation, and concerns around food, financial and food insecurity, we found. And marginalized and at-risk groups face significant impact, with elevated stress and depression, anxiety, and lower resilience because they're lacking access to countermeasures. So you can see it can easily be compounded, and add to it also discrimination and racism. And we know racialized communities can face additional barriers when seeking assistance from the police, or systemic barriers as a result of embedded systems within our colonial structures. And such impediments, as we know, and SURF is working on, it's part of this, as well as uprooting any systemic barriers, practicing greater transparency, integrity, and building trust among our communities and partners. So in rural settings, some amplified stressors that we found, the agricultural sector had already been facing many food system disruptions and economic stressors. Darren Qualman's work, you'll remember some of this was at the conference in Saskatoon, sort of amplified the concerns around mental health. And we heard from Darren there, as well as others, talking about Canadian farmers also experiencing worry and burnout, as well as greater levels of depression than the general population. And of course, this concern then is about reaching out for help, but if there's stigma attached to it being bold and often masculine, that may hinder help-seeking behaviors, which Andrea found in her research as well. So the stressors can be compounded when we see insufficient availability of mental health services in many rural and remote areas, as Al's describing. And we have inadequate access based on the issue of reliable broadband and internet services. So of course, these compound issues, and of course, it was a delight to hear Minister Monsef this morning and the Prime Minister speak to some of these infrastructure questions. So how some of the stress is manifested, we're seeing elevated levels of family violence and spousal abuse that Katie will be speaking to, a neglect of self-care, a greater sense of worry and anxiety. Also, as the story of Betty reminded us, that isolation and dislocation, how compounding and disruptive they are. Heightened fear and uncertainty, trauma and depression, as well as very practical things. Here we are all trying to work at home, and it also affects our own capacity, perhaps our stability and ability to concentrate. Many in rural settings also are facing a loss of job, and income has been greatly disrupted during COVID-19. And even the future is in doubt. Job prospects aren't clear of how that will be retained, and precarious nature of work is a cause for great concern for us. So stressors also experienced in rural Canada can be exacerbated by these conditions with greater disruption, social isolation. Not a pretty picture. So some of the ripple effects also we anticipate, we saw threats to the Canadian Seasonal Agricultural Worker Program that brought major financial and personal stress, not just to the farmers, but also the farm workers and friends and family of those who are relying on that program. And this has led to an undermining of our ability to develop a sustainable food supply, and likely is eroding Canadian confidence in food sovereignty, sufficiency, and food security. We didn't cover that in our paper, but there are other insight papers that speak a bit to these issues around food as well. An added complication during the pandemic is that we have less available resources, and they're less accessible for those that are available. So professionals within school systems or in religious organizations or voluntary bodies, family and access to even public health were less available. So the interactions with individuals, families, and communities were greatly decreased. So side conversations with the school nurse about difficulties, for example, that previously may have helped to solve or reduce an issue, those kind of serendipitous connections are no longer possible, and the aid provided through those connections also was lost. So even prior to COVID-19, a 2019 report by the Canadian Medical Association shows that Canadians were concerned more about healthcare services and growing levels of illnesses, including diabetes and cancers and others, more than the economy. And for many, this manifested in feelings of eco-anxiety. And this is a stress about the future and a sense of disempowerment and disruption to life as we know it. So in addition to COVID, we have layered upon that this issue of this stress around our environmental state. And rural and urban Canadians have had many stresses, and many have ranked climate crisis as a great threat facing them and their future generations. So how do we respond rationally to threats? You know, what becomes a pathology? What about anger or being anxious about climate change, healthcare crisis, or about the oppressive nature of this communicable disease and how we've been forced to isolate? We may feel lost, distressed, grief, or even fearful about visiting with our families, people we love. We're worried for them and worried possibly for ourselves. We may feel distressed when a woodlot is cut down, or we may even be anxious about going to see our doctor. You know, such reactions are not necessarily pathologies. It's reasonable that we react with distress to adversity, but finding ways to get through these traumatic times need sensitive and sensible approaches. So some proven strategies that we found in our work is that resiliency comes out of many things, but being self-directed, being attentive to and helping others is a factor that contributes to people's well-being, sharing a sense of responsibility, collaborating on sustainability strategies. We found in previous work, stewarding the land and protecting the natural magnificence was something that many community members in rural settings were able to work together around, and being skillful around adapting to external and internal stresses. So you can see here a list of largely self or individual factors, and we're going to speak more to systemic and roles of the public, the government sector coming up. So some of the strategies we found that were underway in Canada, many groups were starting to organize weekly webinars, ways like this to gather people. Even if we couldn't get together and hug and share a beverage, we can get together and connect in this manner. There was an illustration of a community-wide event of outpouring of love through gathering and sharing of food, the Chatham-Kent Miracle 16, where they gathered more food than ever in the past. And it was a real event for the community to come together. We saw many national surveys underway, trying to get the pulse of people, giving people an outlet to express themselves, as well as remedies being proposed coming out of those surveys. And the Keystone Agricultural Producers of Alberta hosted a webinar on resilience that had tremendous national uptake. And these kinds of efforts were some of the ways in rural settings where people could reach out and reach in at the same time. So we have a three-part recommendations here for our friends in government and others. So government in Canada, we recommend consider a rural lens in its effective delivery of mental health and well-being supports. And we did hear the minister this morning speak about a rural lens. We want to also encourage the government to promote its Wellness Together Canada portal. It's a superb system online, and we have a reference here for you that speaks to strategies people can use to respond to challenges, but also in preventative approaches. And it's a really good portal that I highly recommend. Thirdly, we recommend that we prioritize the importance of access to information, access to opportunity through well-structured broadband internet access and infrastructure that is affordable. So residents can stay connected, reach out, and be able to get services and do business internationally as well. We also have found that it's necessary for the rural expertise to be tapped into, and we want to advise government to ensure that they're utilizing local talent for strategies that are local and durable, because they're most aware of what will work. And lastly, in our recommendations, we suggest government be investing in efforts to form infrastructure for communities that enable members to stay healthy and to be able to access well-being initiatives. And the government should seek input from and provide funding to rural nonprofits and voluntary organizations, because they're best positioned to build around the resiliency of communities and women's groups like Katie's going to be speaking of. And we encourage rural residents to seek professional help in the process of these very tumultuous times. We don't need to feel like we're doing it alone. So building resilience and connections, mental health is something we all must work on, but likely we do not achieve it alone. We co-create it with our families and our friends and our community and our cool network of fun people in surf. And we celebrate our learning and our success together. And I really advise that we help people take stock of small signs of feeling better in these difficult times, and that we respond productively to stressors and help our friends and family to acknowledge that these are difficulties that we're facing, but finding healthy strategies to deal with them. So you might be happy to know that there is a bright future ahead. This is the result of a meta-analysis of several world studies on happiness. So although in our middle ages, many of us in this downward spiral, you'll see that overall, almost in all these studies, happiness grows over time. We come in this U shape, and although in our 40s and 50s and 60s, we may be in the thick of things, perhaps at our lower level, but it's interesting to see that the research suggests that most people start to enjoy a greater sense of happiness and well-being into the golden years. So some of the resources that we point people to, that wellness portal, highly recommend it, as well as the Canadian Index of Wellbeing, and the Ontario Veterinary College is using some really good work there as well. And our resources, and a big thank you to SURF for organizing this, Ashley and friends, and over to you, Laurie.
Thank you, Kathleen. And for ending on such a positive note about happiness, because I think we needed that, and you're the perfect person to deliver it. When you mentioned eco-anxiety, it reminded me of a film that was made by a Prince Edward Island filmmaker named Milfior Clark, and it was called Solastalgia, which is, I didn't know this word, I don't know if it's new or not, but about the anxiety that is felt from climate change. So, and it's a beautiful film, and I highly recommend it. All right, our third speaker and final speaker today on this panel is Katie Allen, who I know very well from our surfboard, and as I know Kathleen too, because we both are on the board this year. Katie is a PhD candidate in the School of Environmental Design and Rural Development with the Ontario Agricultural College, University of Guelph, and I suspect she knows Al. And I would invite Katie to come and speak to us about gender-based violence in rural and remote communities. Katie.
Wonderful. Thank you, Laurie. I'm not a candidate yet. Hopefully soon. And I do have the wonderful opportunity to work with Al. Al is my supervisor. I'm very lucky. Okay. All right. So good afternoon, everyone. Thank you for the opportunity to speak today. I want to begin by acknowledging that the land in which I live and work is the traditional territory of the Mississauga and Anishinaabe. And I would like to thank the Mississauga and Anishinaabe for the opportunity to be able to join you from their territory today. As a settler, I'm grateful for the opportunity to live and work here and thankful to all the generations of people who have taken care of this land. I recognize and deeply appreciate their historic connection to this place. I also recognize the contributions of the Métis, Inuit, and other Indigenous peoples have made in both shaping and strengthening this community in particular, and our province and our country as a whole. And as a settler, this recognition of the contributions and the historic importance of Indigenous peoples must also clearly and overtly connect to our collective commitment to make the promise and the challenge of truth and reconciliation real in our communities, and in particular to bring justice for murdered and missing Indigenous women and girls across our country. So I'm going to speak today on gender-based violence in rural and remote communities, impacts from COVID-19. The COVID-19 pandemic has created unique circumstances of converging factors that have deepened the vulnerabilities of gender-based violence for women in rural and remote. Social and physical distancing has also created a unique environment that has amplified the impacts of rural and remote isolation. Shocks to the economic, health, and social sectors have highlighted the imperative for women to access essential services through women's sector organizations. And other contributing factors include the uncertainty and instability created by the pandemic that's also impacted how women's sector organizations can deliver programs and services, really deepening challenges and resource scarcity, and created operational and financial instability in an already chronically underfunded sector. So, there we go. Okay, so I will roll into the presentation by looking at three key messages to emerge from this work. First, there is a lack of transportation options, and geographic distance further isolates women. Secondly, some rural and remote communities do not have access to reliable broadband and telecommunications infrastructure, and this can impact the ability to call crisis phone services and reduces access to digitized programming and online sessions. And thirdly, women's sector organizations already struggle to maintain organizational capacity to continue delivering those essential programs and services to their communities. COVID has made this challenge more difficult in an already, as I mentioned, chronically underfunded sector. So the issue, this is an incredibly complex issue. However, I will take a few minutes to discuss some of the contributing factors. Gender-based violence is an urgent social issue that costs women their lives. So COVID-19 has created a state of precariousness, uncertainty, and economic instability. And the intersection of these factors, along with perceived loss of control in daily life, contributes to an increase in gender-based violence. Why this is particularly unique for rural communities is public health directives on social and physical distancing exacerbate isolation and further enable perpetrators' ability to control those experiencing gender-based violence. Mandatory lockdown protocols have prevented face-to-face support services, further reducing opportunities to build those relationships with social service practitioners, seeing family members and friends, and reducing opportunities to leave. Another challenge that contributes to the broader issue is access to, as we've mentioned a number of times throughout the day, reliable broadband and telecommunications infrastructure. Limited, or in some cases, there's no connectivity, then this has impeded women's access to crisis and support services. This has also been a barrier to communicating COVID-19 public health related messaging. So typically in rural and remote communities, outreach and at-home visits can address that lack of transportation and internet and telecommunications service. However, COVID-19 had shut down outreach and in-person visits. So critical to this issue is the inability for women to communicate, whether that be through telephone or online or through in-person visits. It is important to note that some programs are running again, with precautions, of course, but many are still operating online. Another important contributing factor is that COVID-19 has amplified structural gender inequalities in rural and remote communities. So gender divisions of labor impact employment trends. In rural and remote communities, women tend to be employed in education, in healthcare, in social service sectors, which COVID-19 has directly impacted. In some communities, these jobs are well-paying and stable. However, as we heard earlier, in many other communities, these jobs are low-paying, part-time, and contract positions. So of course, this is a complex narrative. Employment security can impact economic dependence on perpetrators, making it even more difficult to leave. And more specifically, in rural and remote communities, a lack of diverse employment and traditional gender stereotypes further impact employment options. Implications indicate that COVID-19 has deepened the potential for economic dependency. Other factors to include are immigrant and racialized and Indigenous women may also experience added barriers. During COVID-19, rural services may not be culturally sensitive, and there may also be language barriers that prevent women from reaching out. So these issues further isolate women from receiving the support services they need. And critical to the response of gender-based violence is the ability for women to access essential social, health, and support services. The COVID crisis has uncovered several gaps in the system and widened them, essentially breaking down really critical social structures. So just shifting to some of the challenges for rural service providers. And I'll start with the pressing issue that budgets tend to be rigid and inflexible to added pressures placed on services. Financial instability and budgetary restraints restrict the ability to innovate service and program delivery. It's important to note too that many of the positions in those rural and remote women's sector organizations are part-time. There's little staffing or limited staffing and financial capacity to pivot those staff roles and supplement volunteer positions is really quite restricted. Over the past several decades, the women's sector has experienced chronic underfunding. I've mentioned that a few times. It's an important piece. Funding for nonprofit and charitable women's sector organizations typically is through patchwork of unpredictable sources, such as individual donations, corporate gifts, and grants. So this type of project-based contract funding has left the sector financially fragile and sensitive to the fluctuations and political shifts in funding cycles. So since 2015, there have been increases to the Women and Gender Equality Department budget, and that has provided a much needed boost in funding opportunities for capacity building in the women's sector. However, access to stable and core funding for the women's sector organizations in rural and remote communities is imperative for stability and continuity for delivering essential services in areas with limited resources. So, in response to COVID-19, social and physical distancing protocols, community outreach support programs and services are not being offered face-to-face, typically. To continue providing those essential programs to women, the women's sector organizations have shifted to online meeting sessions, and they have digitized programs. The response addresses social and physical distancing requirements. However, it presents significant barriers for rural and remote women to access support. Unfortunately, because of this, many women are going without support because they don't have the tools or the technology to access those digitized services or attend online sessions. Accessibility really is a critical issue, and may not be addressed by technology in rural and remote. But for those that can access online tools, there are several options for women to reach out for help. And so there's new chat and text options that are available by women's services and women's service organizations to provide discreet ways to let someone know that they need help. The Canadian Women's Foundation has also created the Signal for Help. It is the open palm, tucked thumb, and then fold your fingers over top. The Canadian Women's Foundation has also created the Tireless Together Fund, and that is a national emergency fund aiming to help vital services reach women and girls by providing grants to service providers. So to conclude my presentation today, I'll go through the recommendations that emerged from this insight paper. Gender equality is a cornerstone of inclusive and sustainable development. And the integration of gender-based analysis plus, GBA plus, in post-COVID-19 recovery policies is really essential. As realities change, integrating GBA plus will provide opportunities to address some of those structural and structures that perpetuate gender inequalities in rural and remote Canada. Ensuring core funding for rural women's sector services will provide that financial sustainability, or financial stability for organizations and increased resource capacity to deliver those essential programs and services. Core funding is critical to build a resilient women's sector. And this is particularly relevant in rural and remote communities where the funding has been eroded and capacity and resources are really stretched. And the final recommendation is to collect data to understand the current situation for gender-based violence in rural and remote communities. This is a critical time to gather data on the unique impacts of COVID pandemic on gender-based violence. So data collection on different stages as well can offer insights into how to strengthen and support women during emergencies, and how to address gender-based violence in times of crisis. So with that, I would like to thank you for listening today, and thank you for your time.
Thank you so much, Katie, for that great overview of what's going on in rural Canada in relation to gender-based violence. It's incredible, and we don't hear enough about it for sure in the media. There's been some lively chat going on while we've been speaking, and we have about maybe 10 minutes for some discussion. And I just thought maybe one way of trying to capture a bit of some of what's been going on in the chat and the questions that we've had, if each of you might like to take a couple of minutes to address something that started out with Peter Smith's question: is geriatric research going on in any rural communities? I'm just wondering if each of you might say what kinds of research in the areas that you're working on is it going on? And then another, Shirley Thompson was asking about First Nations communities and access and to healthcare and services. If you know of any research that's happening in that regard, and thanks, Kyle, for pointing Shirley to the State of Rural Canada 3, talking about Indigenous communities. That's terrific. So is there enough there for each of you to take, 2 minutes and just expand on some of those thoughts? And who would like to go first? Kathleen, thank you.
Sure, and thanks to Deb Morris for the question and the comment about do more ag. That's really a helpful link to mental health services. So of course, in most communities, there are public health providers, and there are for-pay service for psychologists and others. But as we know, many times those are not so readily available. So the research is the research is growing, and the bodies of research continue because we have brilliant people doing good work, but the emphasis on rural needs more attention. We have seen disparate pieces of the work, and certainly some of what Andrew and I were trying to do with this, looking at some of the bodies of work that we examined. It's not collected in one central location, but certainly now with this ministry, maybe we will see more of that. Maybe that also can be helpful repository for us to channel more of our research about challenges in rural settings, but also the solutions and the strategies that communities are using, whether they're tapping into other local capacity, using psychologists from schools, for example, to also extend hours and make them available in community settings as well. There's different ways that resources can be tapped into. But I dare say that there is, as we've noted, great gaps in what is needed and what we're able to access at this time.
Thank you, Kathleen. Al, would you have anything to
Yeah, just a couple things. In terms of, I'm not a geriatric researcher. Anybody interested in that, I would suggest you talk to Kyle Whitfield at the University of Alberta, who specializes in planning and geriatrics. I'm currently engaged in one study looking at seniors and food insecurity, and we're halfway through that study. COVID put a little bit of a hold on it, but one of the things I think I found really interesting last year when we interviewed service providers and when we talked to physicians about seniors, and so we were looking at food security, and we asked them, do you talk to seniors about diet? Do you have a sense? Do you do sort of the social history? Do you check in with them on income and availability of food? And essentially the physicians said, well, if it's a diet related issue, yes, but otherwise we don't really check in with them. And so there were really differences in terms of service providers' perspectives. I think certainly the PSWs that went into the home had a very different perspective than the physicians, and actually a more grounded, because they're seeing individuals who they're seeing where people live and what they do. And they talked about opening the fridge and there's nothing there, or the food's gone bad, and things like that. So that's about my extent of sort of engagement with seniors. I think it's an incredible need, particularly in rural areas, and the resources that are not there, and the type of social isolation that comes about in rural areas for seniors. One of the things the physician said, one of the most tragic things that can happen to a senior in a rural area is to lose their license. And then they become trapped, and they become dependent, and they give up their independence. And when you give up your independence, you're also giving up, in some ways, your access to making meaning in your life, that autonomy, especially for older people with different generational historical backgrounds. That autonomy is very important to who they are as individuals. So it can be a very trying time, and that, coupled with the absence of resources that are available, specialty resources. So first of all, GPs aren't, and family physicians aren't necessarily trained in geriatric conditions. And the second side of that is physician shortages. Not everybody, what happens to a senior who doesn't have a physician? They become an orphan. There's nobody to manage, do their case management in terms of they suffer from sort of multiple morbidities, which are quite common in rural seniors. But I'm going to stop there and leave some time for Katie.
Thanks, Al. Katie?
Wonderful. Thanks, Al. So there's definitely research going on in this area, and particularly looking at the different components of what I talked about today. Particularly looking at the health pieces and social care and services, and the chronic underfunding for service providers. But I think what we really need to look at is how to fund sustainably essential services to ensure that that they will be available to people living in rural and remote communities.
Thanks, Katie. That leads into another question that someone asked about core funding. And so it made me think about if you could sit down and have a coffee with Minister Monsef, what would you ask for? You know, is it core funding? Is it something else? Just your thoughts.
Sure. So I would ask for core operational funding, funding that would provide enough financial sustainability and stability for organizations to operate. So it wouldn't be the project-based funding, it would be that core operational funding for the organizations to keep the lights on and the doors open and the staff paid.
And to that question, I would ask for resources. I like Katie's response, but also train the trainer model, that we build such capacity in rural settings already. There's such a communal effort and orientation. So I would look to amplify that, but also professionalize some of the assistance, and people can get credit if they will partner with us. And I just want to make a comment that Heather Sanson should get in touch, because I happen to be a psychotherapist. I don't practice currently, but I had for 10 years, and she was talking about being a therapist in rural settings, so we could talk further about that.
Can I just comment on that? And I'll take an opposite sort of position, because one of the things that the governments are facing are massive deficits. And going with our handout, I agree with Katie and Kathleen. I think there needs to be investment, there needs to be core funding, but I think we need to be really creative and innovative in how we approach things. I think we really need to rely on communities to develop those innovations, and government needs to find ways of investing their dollars into the creativity and innovation of rural people in response to the types of challenges they face, because different communities face different challenges. And so I think we really, we talk about place-based policy, and what is place-based policy or place-based development, and how do we mobilize local resources to respond to their needs and challenges, and what is the role of government in doing that in a time when money's going to be short. That's the reality of it. Money's going to be short all over. And yeah. So anyways, I think we have to be really creative.
And I think that's a watchword for all of us. And rural Canadians are really good at it, I think. And so let's bring out some more. Let's encourage it. Community capacity building, train the trainer, all of those kinds of things. And as you say, Al, we're going to be facing a massive debt. Let's use our ingenuity to get us through this. I think we should wrap up because we only have a couple of minutes left before we turn into pumpkins here on our on the webinar. I would like to thank you all for your wonderful contributions today in bringing these issues to light so concretely. Your work is on the ground, real people, real things that we're dealing with in rural Canada. And I urge everybody that's all of our attendees and help spread the word about the Insight series that are equally as strong as these ones. So thank you again, Al and Katie and Kathleen, for your work on this series and today on the webinar. We really, really appreciate it. Ashley, did you want to jump in and say a couple of last words?
Yes, thank you to everyone. Thanks to Laurie for moderating this session, to all of our participants for coming up. Thank you to all of our panelists. Thank you for your contributions to the series and for your speaking today. It was really thoughtful and reflective and I think some important conversations. So thank you, everyone. Thanks, everyone.
Thanks, Ashley. Bye.